Welcome to The Explainer. Today, we're breaking down the clinical management of melanoma. It's a cancer we're definitely seeing more of, but you know what? Our ability to treat it has absolutely transformed. We're going to walk through all the essentials, from diagnosis and surgery, all the way to the game-changing systemic therapies. This is designed to be a super high-yield overview, especially for medical trainees. So here's our game plan. We're going to follow the path you would in the clinic. We'll start with the primary tumor, then we'll get into surgical management and nodal staging, cover the incredible advances in systemic therapy, and then wrap it all up with the key points you need for patient follow-up. Okay, let's start with the basics. The most important thing to remember is that while melanoma can be really aggressive, it's also highly curable when you catch it early. And that brings us to the single most critical piece of information you'll get from that initial biopsy. And that, right there, is the Breslow depth. This one measurement is literally the key that unlocks the entire management plan. More than any other factor, it tells us the prognosis of a localized tumor, and it directly dictates every single one of our next steps. Everything hinges on this number. So, based on that Breslow depth, we can map out our plan. For early-stage localized disease, the treatment is fundamentally surgical, what we call a wide local excision. But the million-dollar question is always, how wide is wide enough? All right, here's a classic clinical scenario. You're on rounds, and a patient's path report comes back showing an intermediate thickness melanoma. Your attending turns to you and asks, what are the recommended surgical margins? Well, the good news is, you don't have to guess. It's based on very clear, evidence-based guidelines. And you know what? The standard of care is actually elegantly simple. For our 1.5 millimeter lesion, it falls smack dab into that middle category. That means a 1 to 2 centimeter margin is the correct answer. It's a really straightforward guideline, and it's driven directly by that initial pathology. Okay, so we've dealt with the primary tumor. But here's the thing. As that Breslow depth increases, so does the risk that the cancer has started to spread to the nearby lymph nodes. So our next job is to figure out that risk accurately. This is exactly where the sentinel lymph node biopsy comes into play. We generally recommend it for most tumors thicker than 0.8 millimeters or for ones that have other scary features like ulceration. It's a really smart, minimally invasive way to find out if the cancer has begun its journey beyond the skin. Now this is a huge deal. It perfectly illustrates a major paradigm shift in how we care for melanoma. It used to be that if a sentinel node was positive, you automatically got a full completion lymph node dissection. I mean, we take out all the nodes in that area. But then, landmark trials showed this caused a lot of problems, like lymphedema, with absolutely no benefit to overall survival. So today, the standard of care is just observation with regular ultrasounds, and we think about giving adjuvant systemic therapy. Okay, so let's pivot to patients with stage 3 or metastatic disease. If there's one area in all of oncology that has been completely, utterly transformed in the last decade, it's this one. The prognosis for these patients has improved so dramatically, and it's all thanks to two main strategies. Now, to really get these therapies, we have to look at the genetics first. About half, I repeat, half of all cutaneous melanomas have a specific mutation in a gene called BRAF. Think of this mutation as locking the gas pedal to the floor in the cell's growth pathway, just telling it to divide, divide, divide. And that right there gives us a perfect therapeutic target. This leads us to our two pillars of treatment. For patients who have that BRAF mutation, we can use targeted therapy. These are oral pills that go in and directly block that faulty growth signal. It's like cutting the fuel line. For everyone else, and often in combination, we have immunotherapy. This doesn't target the cancer itself. Instead, it unleashes the body's own T cells to go on the attack. It basically takes the brakes off your immune system. And the progress we've seen in immunotherapy has been just breathtaking. The first-generation drug, ipilimumab, gave us response rates around 20%. Then came the next wave, the anti-PD-1 antibodies, and that pushed the number up to 30-40% with a much better safety profile. And now, combining them can get you response rates over 50%, completely rewriting what's possible for patients with metastatic disease. All right, let's bring it all home. Let's distill this all down to the absolute key takeaways for managing melanoma. The key takeaway is actually pretty simple. Early-stage disease is a surgical problem, and it's highly curable. Advanced disease is a systemic problem, where we now have these incredibly powerful tools like targeted therapy and immunotherapy that have just fundamentally changed the game. And please remember, our job does not end after the initial treatment. Lifelong surveillance is absolutely key. This means we have to empower our patients, teach them how to do skin self-exams, and make sure they have regular follow-up with dermatology. And just as important, for those early-stage patients, we avoid routine scans that don't actually improve outcomes. This field is moving so incredibly fast. We're already seeing new checkpoints like LAG3 inhibitors pop up, and we're even using immunotherapy before surgery in what's called the neoadjuvant setting. It really leaves us with an exciting question. What breakthroughs are the next 5 years going to bring, and how much further can we push the needle to improve survival for our patients?